So in the San Antonio, we presented a study evaluating the SETER assay as a predictor of extended letrozole therapy benefit in the NSABP B-42 trial. And B-42 trial is a trial where postmenopausal women with ER-positive breast cancer, stage 1 to 3A, being disease-free after 5 years of adjuvant endocrine therapy, either with an aromatase inhibitor or tamoxifen, followed by an aromatase inhibitor. They were randomized to 5 extended letrozole therapy for 5 years or placebo for 5 years. And the study has shown significant benefit in disease-free survival, breast cancer-free interval distant recurrence, but the benefit was modest, in a range of about 2 to 3% absolute benefit, which underscores essentially the need to try to develop better predictors of risk of late recurrence and also predictors of benefit from extended endocrine therapy. And along those lines, we evaluated SETER, which is a biomarker including 18 genes that based on transcriptional activity of the estrogen receptor, as a predictor of extended endocrine therapy benefit in B-42. So we had two hypotheses. One was that the benefit from the discrimination in terms of benefit by the ERPR was focused mainly on the patients that were in the middle of the distribution curve of ERPR, between the interquartile limits of 1.1 and 2.1, and the low-risk patients would not have benefit. Low SETER patients would not have benefit from extended endocrine therapy because they were relatively insensitive to endocrine therapy, and the high end of the curve, the upper quartile, would benefit also not much because they were so sensitive that the first 5 years would have been enough. The second hypothesis we had is whether a cutoff in the middle, essentially 1.5%, higher than 1.5, would benefit more patients with extended endocrine therapy. So when we looked at the data, actually, when we looked at the first way, the middle 50% versus the quartiles 25% on each side, there was no significant benefit. But then when we looked at it according to the cutoff 1.5, greater than 1.5, we saw significant benefit in the high SETER and no significant benefit in the low SETER, although the interaction was not statistically significant. And then we looked at it as a continuous variable, and as a continuous variable, as the SETER went up, so did the benefit for extended letrozole therapy. And then we also looked at it according to different categories, less than 1.1, then 1.1 to 2.1, the second category, and greater than 2.1. And in that categorization, we saw no benefit in the low end, good benefit, about 35% reduction in the middle end, and then even more reduction in the higher end, over 2.1, almost with a 75% reduction. So essentially what we showed in the study is that SETER can be used to estimate the extent of benefit from extended aromatase inhibitor therapy in patients that are received it after 5 years of initial endocrine therapy.